hope you had enjoyed the fine Neurophilia series session 1 that was regarding stroke basis. And I am sure this session would be not only useful for the people who are going to give the DM entrance exam, but also those who are working as physicians as well as those who have already entered into neurology. I would like to congratulate all of those people who have joined DM courses all over India. Today I got many calls regarding their selection in the second counseling of Neet. All had just one thing to say in common, and that was to read Harrison. And there is no way you can skip this step of entrance preparation. So read your Harrison well. Later we'll go on with the Bradley, and also, as I had advised you previously, revise your all the old topics which you have studied during your MD medicine and pediatrics, as well as during your MBBS. These are the portions in Harrison and Bradley you are supposed to read. So let's revise with just one question from the previous class, so that I will be able to know whether you have prepared it properly or studied or followed the previous session. So this is a patient who came to my OPD just 2 days. Monday morning she had come to my OPD. Back. Video is very fast, I will tell you. Asking to look her to the right, she is unable to do it with her right eye, but left eye it was normal. The grip is weak in her left hand but strong in her right hand. And her mother had complained she had insidious onset, slowly progressive weakness of her left side. So as we know, we have studied in the last class regarding localization of brainstem syndromes by Peter Gates. I'll ask you to all to answer. If you have confusion regarding this simplified rule of 4, then please let me know. And or otherwise you can just see the YouTube which is seen in the fine YouTube link. So this was regarding our Peter Gates, who described the rule of 4. All we know that the midline structure starting with M, the lateral sideways structure starting with S, and the 4 nuclei and the divisors of the 12th number 12 will be considered as medial nuclei. So medial structures, lateral or side structures, the nuclei, that is 3, 4, 6 and 12 will be in the midline, that are mainly motor nuclei, and 4 nuclei in the cranial nerves, 4 nuclei in the pons, and 4 nuclei above pons. So in our case, we had a left-sided weakness which showed that there was corticospinal tract involvement of the right, and the right lateral rectus weakness, that is abduction weakness to one side, suggested it is actually a medial pontine syndrome. So this was actually not a case of stroke. That is the importance. It was just actually a lesion. It's almost looking like a glioma over the right pontine region. So with this, we'll start the topic proper. So I want everyone to answer this question. This is one of the most common questions which have been asked recently. I have seen in multiple papers, repeat question, it comes as a repeat question. Common lacunar syndrome is actually pure motor syndrome rather than ataxic hemiparesis. In clinical setting, we get mostly ataxic hemiparesis as a finding, but most common syndrome is actually lacunar syndrome is pure motor syndrome. Pure motor has about 45 to 50. That is half of the lacunar syndromes are due to pure motor hemiparesis, are due to pure motor syndrome. So lacunar syndromes are, as you all know, it's the size of the lacunes is less than 2 centimeter. And that is the thing. So next question would be, this is actually what we had failed to discuss in the last time. Some rare causes of stroke, which are a very high yield topic these days. So you can take your time and try to answer this, whether fibromuscular dysplasia affects the cervical arteries and occurs mainly in women, whether it is female predominant disease, whether anticoagulation is necessary to be continued lifelong in case of venous thrombosis when we have a thrombophilia. Moya disease is a progressive atherosclerotic stenotic disease. We know that it's a highly stenotic progressive disease. Although rare, it is found. And that CADASIL usually is associated with migraine with aura in their younger age group. Fibromuscular dysplasia affects actually cervical arteries mainly and occurs mainly in women. And anticoagulation, if you find a thrombophilia, it is prudent to continue and medications for lifelong. And moya disease actually is a progressive stenotic disease, but it is not a atherosclerotic disease. And Caracel usually have a migraine with aura in their younger age group during their prime. So fibromuscular dysplasia is actually very rare, but non-inflammatory and non-atherosclerotic vascular condition, just the opposite of atherosclerosis. And there is abnormal growth of the cells within the walls of the arteries. You know about the walls, that is tunica media, tunica intima is the innermost, tunica media, middle, and the tunica adventitia in the outside. And usually affects the carotid arteries. And these fibromuscular dysplasia patients present with stenosis resulting in stroke, ischemic stroke, and also maybe due to arterial dissection, which presents as stroke, and can present even as subarachnoid hemorrhage due to aneurysm formation within the fibromuscular dysplasia. The classical string of beads appearance, this is the angiogram of a string of beads pattern we see, is classically seen in, string of beads pattern is classically seen in fibromuscular dysplasia. You can see the string of beads appearance. And once you hear the term moya, the first thing which comes to your mind is puff of smoke. I'm not sure how many of you are aware of more about moya. It is a very wonderful syndrome, and it's high yielding topic, especially in the institute exams, where the surgeries for moya are in case of Sri Chitra. So first we'll think of puff of smoke in angiogram. So moya disease is different from moya syndrome. Moya disease is an idiopathic syndrome causing non-atherosclerotic stenosis. But moya disease is actually, moya syndrome is actually secondary syndrome. Moya disease is the idiopathic one. And moya syndrome could be due to secondary causes like autoimmune angiitis, as in case of SLE, in case of patients who are receiving irradiation, and also due to secondary to chronic meningitis. Even hypothyroidism has been shown as a culprit in case of moya syndrome. So moya syndrome was first described by Suzuki, and he had started the grading for, he graded this moya disease into 6 grades. It's not needed to study these grades. Just to know, you should know that the moya affects the large arteries, basically the internal carotid as well as the middle cerebral and ACA arteries, not the small ones. So first, usually we find a narrowing of the artery, that is stenosis of the internal carotid artery. It may mimic a carotid atherosclerosis. Later, because of this block, the brain tries to compensate by producing collaterals. And collaterals, when it starts to occur or try to compensate from even the external carotid vessels, we should understand that disease has progressed much. And when complete absence, then it is the last stage, that is the grade 6. And we have actually surgical procedures being done in Sri Chitra for this moya disease. You can either do a bypass or you can do something called as synangiosis. You should keep that in mind. So that was regarding some rare syndromes of stroke, fibromuscular dysplasia, moya disease, cerebral venous thrombosis, etc., Caracel and Caracel. So this is also a high yield question. If you can answer, please give your option. I have launched the poll. Try to answer it. Which of the following is not actually a monogenic cause of stroke? This also is a repeat question. I didn't change the option so that you shouldn't feel that it is tough. These are all there in the Harrison, each chapters, but it's kind of hidden in specific areas. So usually you know that stroke has a polygenic cause. That is, it will be most common risk factors would be hypertension, diabetes mellitus, smoking, other risk factors which have a polygenic cause for stroke. But sometimes some specific monogenic causes are there, stroke are also identified, but they are rare, but they are present. As in case of Fabry's disease, Caracel, Hearns, this is Hearns as an entity which is even given in Harrison, but it's very rare. And regarding Binswanger's disease. So the answer is actually Binswanger's disease. This is actually a cerebral vascular disease, and the others are actually monogenic causes of stroke. So where have you heard this sign called O'Sullivan sign? So this is actually O'Sullivan sign is actually the hyperintensity seen in the temporal region in either the T2 weighted or the FLAIR image in an MRI, and is seen in case of CADASIL patients. So this kind of white matter intensity seen in the temporal region is otherwise termed as O'Sullivan sign and is seen in CADASIL patients. So CADASIL, as you know, is due to the Notch3 mutation, cerebral autosomal dominant disease with subcortical infarct and leukoencephalopathy. So usually the patient presents with migraine in the initial prime age, that is 20 to 40. Later, by about 40 to 50, they start to get strokes. And later, because of this side effects of this stroke, they develop dementia and other mood disorders. This is the usual progression of CADASIL. And something called osmophilic material deposits are seen in case of electron microscopy in the vessels. Herns has been described, and it is actually a combination of syndrome of endotheliopathy, the endothelial vessels the region becoming affected, along with retinal involvement, brain involvement in the form of stroke, and kidney involvement. So eye, kidney, brain disease is not the same. The affection is in these areas. And CADASIL is actually a counterpart of CADASIL, and you should remember that it is due to the HTAR1 gene, which is present in the chromosome number 10 in this patients. So HTAR1 gene you have to remember and keep, because this could be the next entrance question. And I would like to bring to your notice that this CADASIL was described, usually the patient will be having alopecia, some kind of spasticity, as well as lumbar disc disease, along with lumbar disc disease. And this was described by Japanese doctors, by Maeda and Nimoto, and hence these could be asked eponym, that is, CADASIL is otherwise called Maeda syndrome or Nemoto disease. You can keep that in mind. So that was regarding the monogenic causes of stroke. And Fabry's disease, as you know, there is angiokeratosis, and it is due to mutation in a gene, GLA gene. And you have to study, Fabry's is a high yield topic also. So last class we had studied regarding the CHAD-S2-VASc score. As you know, it is the scoring system to prognosticate stroke risk in a patient having TAA when the patient had already atrial fibrillation. So my question is actually, can all answer this question? That is question number 5. That is, the risk of TAA after stroke is best calculated with which one of the following scores? Can try to answer. Yes, actually there is no much confusion, but still people are going wrong. Even CHAD-S2-VASc score is used, but usually CHAD-S2-VASc is used mainly in case of patients with atrial fibrillation. So basically, along with TIA alone, usually the scoring is actually the ABCD2 score. Hasbled scoring has been used in bleeding. Barthel index is another way of grading stroke disability along with NIHS. And CHAD-S2-VASc we have already described. So ABCD2 score, we have many questions could come in from ABCD2 score actually. Because you could get a question like 76-year-old male presenting with BP of 150/90 with speech abnormality, with weakness lasting less than 60 minutes, and who is not a non-diabetic, then what is the risk factor? You just keep in mind that something there is called ABCD2 score. And some imaging criteria with a point added of 3 has been given for ABCD2 score. So for better prognostication. This stratification, that is ABCD2 score, and Hasbled's, as you have seen, includes also the liver and the renal function test. Which of the following is an incorrect statement regarding among the following? So these are sentences taken from Harrison. As we can see, mitral valve prolapse is usually is not a common cause of this stroke, and PFO, as we think, it's actually not a rare disease. It's usually common. The PFA is actually patent foramen ovale, and it is common. to see. And actually, in case of a if you work up for stroke, especially if you look for a large artery occlusion or an embolic source from the heart, and if you don't find any answers, usually we may think that it could be also due to a PFO. And PFO, as you know, is present in 15% of population. So PFO occlusion device, if given in a patient whom we don't have found out stroke and just have a PFO, 1% reduction, absolute risk reduction is there in stroke. So this is actually given in Harrison. That's why I have taken it. The importance of this sentence is that some terms in statistics like risk reduction, number of needed, has been given multiple times in Harrison. And also recently in the institute exam, especially in AIMS, these questions have come regarding risk reduction, absolute risk reduction, and number needed to treat, etc. And as you know, intracranial atherosclerosis, that is the atherosclerotic vessels, not only causes narrowing of the vessels and causing stroke, these plaques, if they are unstable, can rupture and cause something just like an embolic mechanism, similar to that of the heart embolic mechanism. So the wrong statement is mitral valve prolapse is not that common. If this prolapse is very severe, only we get a emboli in case resulting in stroke. So this is the TCD machine we have in our neurology labs. And what we find in these machines is actually, what you get is actually high intensity signal transients, otherwise called hits, which suggests that there is an abnormal flow. So this is the uploaded device which is used in case of a PFO. So coming to the treatment proper, if you see regarding the treatment of strokes, so much have changed from 1996 up till now, and still it's a highly innovative field. And in 1996, what happened was thrombolysis was introduced with a study called NINS RTPA study, and later in 2015, the thrombectomy was found to be useful from many studies. Previously also thrombectomy studies were being done, but all the studies showed that it was not useful. And regarding the secondary stroke prevention, we have what is called endarterectomy or carotid stenting, so that a patient doesn't get a stroke even when he have a highly stenotic atherosclerotic plaque. So this is actually this sentence has been taken from Harrison, and it's actually clinically relevant question. So this is regarding NASET trial. NASET trial was a trial which was used to assess the importance or usefulness of endarterectomy in carotid atherosclerosis. So according to this trial, what is the percentage? Is it 50%, 60, 70 or 80% of symptomatic, that is the occlusion causing a stroke, was found to be useful, or we should go for a thrombectomy or carotid stenting or endarterectomy if the occlusion is beyond this percentage. So most of them have answered it rightly. Actually, it's 70%. 70% number needed to treat is very much, just 7 in case of more than 70% occlusion, and that is the answer. So as I told you, 50 to 70% has also been tried for thrombectomy with stenting and endarterectomy, but was not as beneficial as the more than 70% study results. And the other thing was found out was that if stenosis is less than 30%, then never go for surgical management because it will harm the patient. So as you see here, this is the NASET criteria. This is not important, it's not that important to you, but just know that we start treating when it's above 70%. And this is the number needed to treat. We have to treat just 7 patients to get a benefit. And if it's 50 to 70%, we have to treat 15 to get a benefit. And in case of asymptomatic side, this is asymptomatic side, even if more than 70%, we have to treat 100 to get a benefit, one benefit from the surgery. So asymptomatic side, we usually don't go for therapy. So as we know, this is due to a plaque formation within the vessel. This as you know, is actually the intimal layer. This is the media layer, and this is the adventitia layer. So intima is this one, media, adventitia. This is very common basic pathology you have studied. But why this atherosclerosis occurs is because if the flow is linear, then nothing wrong happens. But if this flow becomes what you call turbulent, then there will be injury to the vessels. For example, the turbulent flow, as you can find, usually occurs in the arch of aorta or in the bifurcation of the carotid arteries to the ICA and ECA. So as you know, this is the most common site where we find the atherosclerotic plaque causing the stenosis, and uh, that results in this further events of plaque formation. And plaque, if enlarges, and due to some characteristic, if it has got more of lipid rather than the collagen, or if there is a hemorrhage within the plaque, then it is high. It is otherwise, or there is ulceration. It is actually called an unstable plaque, and it can cause an emboli resulting in stroke. So it's better to treat as early as possible when we find such a occlusion within the carotids. And this is actually change in the plaque. Actually, you can see the lipid core. This atherosclerosis causes accumulation of lipid materials within, and further there is intraplaque hemorrhage. There is microcalcification. The macrophages does, and sometimes we, as you know, a question could come. This atherosclerosis is actually affecting which layer of the blood vessel? Is it intima? Is it media? Or is it adventitia, or within the lumen? So the answer is actually intima. But usually when we see the specimen of a pathological specimen of the vessel, you can find that this is actually the intimal region, which is a single layer which has got affected. And there will be a restricting internal elastic lamina. But some secondary changes we can see within the media. These are actually secondary changes within the media which we see in the atherosclerosis of vessels. And as we know, which is the specific disease which affects the tunica media alone, it is actually Mcqs sclerosis. Sclerosis affects basically the tunica media and not the intima. So arteriosclerosis, as we know, is due to stiffening of the arteries. It can either be due to Mcqs sclerosis or due to atherosclerosis. Atherosclerosis affects the intimal layer. Mcqs is actually the calcification within the tunica media, and we are concerned mainly with the atherosclerosis because Mcqs is actually a benign condition. So try to answer. If you have learned statistics only, you can answer this. So I think will not go for the poll for this one. So in the NASET criteria, when the patient it was a comparison between medically managed, that is just with statin and antiplatelets, and the patient managed with both medical and carotid endarterectomy was done. And we found that 26% of the patients who were medically managed developed stroke. Only 9 developed stroke in the carotid endarterectomy group. So actually the absolute risk reduction, or the ARR in this patient, is actually 65. Sorry, not 65, 17. So 17, how will you get? Actually, it is 26 minus 9, that is 17. So the risk reduction with carotid endarterectomy was 17%. And how you calculate the number needed to treat is by dividing this with absolute risk reduction. So number needed to treat is, you can find by, if you are comparing two methods of a management, then just subtract the risk of both modalities, divided 1 by this will give you actually the number needed to treat. What is this importance of this importance of this number needed to treat? As we said, actually in case of NASET trial, they showed the number needed to treat is 7. We just need to treat 7 patients to get a benefit, that is to avoid stroke in that patient. Maybe 6 of them may not get benefit, but definitely the less number of patients needed to be treated to get benefited. For example, we are giving atorvastatin and statins left and right for all cardiac as well as stroke patients. So number needed to treat it for this is actually 100. Even then we are giving. So that is an importance of number needed to treat. So it is not to confuse you. It is just because this has come in the recent exam, the number needed to treat, the risk reduction, absolute risk reduction, and the same sentence were taken from Harrison and not from anywhere else. Because the problem is that when we start reading Harrison, if you take a topic example for stroke, we start with the epidemiology, pathophysiology, clinical features, investigations, and by the time we read treatment, we may just go with the just the treatment and not understand these trials and numbers. And these trials and numbers are recently emphasized in all the institute exams and also have come in the Neet exam. So that is why I wanted to highlight that point with this question.